We shall now go on to our next speaker, Dr. TALVIR SIDHU, who is assistant professor in Government Medical College, Patiala, young, dynamic, smart surgeon. And she is going to tell us about managing late complications of trabeculectomy. The battle is neither over nor lost. On to you.
Am I audible, ma'am? Is my screen visible?
Yes.
I would like to thank ARC for the opportunity, and also I would like to thank my mentors, Professor Sihota and Professor Dada, at the start of this presentation. I have no financial disclosures. When we look at the publications, major publications on long-term complications of trabeculectomy, the CIGTS, which looked at trabeculectomies at 5 years and more, they said that the cataract extraction is one of the most common complications, followed by bleb-related complications like bleb leaks and bleb revisions, which were needed, which were majority of the complications, and almost 1% had hypotony or endophthalmitis at the end. Now, looking at an ideal bleb, as Dr. Ratni has already said, it's a very diffuse, mildly vascular, well-functioning bleb, which is not over-functional or less functional, and the IOP is well maintained. But long-term bleb outcomes, they vary from an ideal bleb. They might become thin cystic blebs, just like this one, or overhanging blebs. And on the other side of the scenario, we have the encysted and flat failing blebs, which might be present. The thin cystic blebs which might be present might have just the conjunctiva overlying the bleb, which has become thin because of use of antimetabolites, or there might be associated scleral thinning, which might be present in the along with the thin blebs. And sometimes the conjunctiva might override the cornea or have very large overfiltering blebs where intraocular pressure might be low along with that. So this is a video which shows that bleb sweating is a phenomenon that might happen as the blebs, they start thinning out. When you put fluorescein dye over the bleb, you can see patches of fluorescein dye becoming diluted. And moreover, in similar blebs, if you put pressure over the globe, you would see that along with the sweating, there are patches of conjunctiva which are thin and they start leaking when you apply pressure over the globe, which is a pressure Seidel's positive test. Sometimes we also see minor leaks in the blebs, which might be present late. So this was a patient who had undergone a bleb revision. And after that, along the suture tract, there was a minor bleb leak that was present. And sometimes profuse leaks. This patient had a trauma, and following the trauma, he had a very profuse leak from the bleb area. So these can be associated with a persistent hypotony, which can lead to visual loss due to hypotony maculopathy if it is present for more than 6 to 8 weeks. And persistent hypotony without any thinning of the bleb might also be present in young age and juvenile open-angle glaucomas, myopias, people presenting with very high intraocular pressures, persistent iridocyclitis, or very high use of antimetabolites. So that can actually be managed with the help of pressure patching or a large PCL. This is a picture which shows injection of autologous blood into the bleb from a paper from Dr. Vijay ma'am. And they have actually given good results after use of autologous blood in the blebs which are overfiltering. But blebs which have sweating or minute leaks, we have tried oral doxycycline. So this was the patient we had seen earlier who had undergone bleb revision because he had prolonged hypotony. And this bleb leak which was present, actually we did not again try to put any other sutures. We just gave him oral doxycycline. And you can see that the hole that was present near the conjunctiva has actually healed. The steroids were minimized, and after 2 weeks of oral doxycycline, we can see that the minute leak that was present has disappeared. Also, bleb revision surgeries may be done for leaking overhanging blebs. In earlier times, we used to use a bare sclera technique where the bleb was removed and the conjunctiva was actually advanced onto the bleb area. If the conjunctiva was not advanced, a flap of conjunctiva may be used from the other side. But the problem with bare sclera technique is that sometimes the post-operative period, the pressures might become high due to fibrosis of the entire bleb. Therefore, Professor Sihota has described this technique of bleb-sparing epithelial exchange. We have separated the conjunctiva around the bleb area, and we have stained with trypan blue the epithelium which is present over the thin epithelium which is present over the bleb area. So we are only removing the thin epithelium which is present over the bleb area, so that the underlying bleb structure which is formed by the tenons is not disturbed. And after this, we can actually advance the conjunctiva over the bleb structure. If we only advance the conjunctiva over the bleb structure, this epithelium makes sure that there is no adhesion of the conjunctiva and it tends to get receded post-operatively. Therefore, this is a very important step while we are doing this surgery. Sometimes when there are scleral thinning also present with profuse leak from the bleb, this was a patient who had a very small area of scleral thinning. Here we actually separated the conjunctiva over the bleb area, and after separating the conjunctiva over the bleb area, we used ologen as a scaffold. We did not use a scleral patch graft over this thin area. We just put the ologen graft over this thin area and sutured it and advanced the conjunctiva over the ologen. And you can see this is a post-operative picture around a month or 6 weeks post-operative picture of the patient, which shows a very well adhered conjunctiva. And this also makes sure that there is some filtering that is happening into the bleb. If we put a scleral patch graft over such small areas, they close immediately and the intraocular pressures post-operatively might rise. So ologen is a very good option in these cases. Similarly, a thin bleb with a full thickness scleral defect usually needs a scleral patch graft. Here we used a scleral patch graft. We used a trephine to cut out a very small scleral patch which was tucked into the full thickness scleral defect that was present. After tucking in the scleral graft, there was also a thinning of the cornea that is actually seen over along the bleb. So therefore, here also we used an ologen graft and advanced the conjunctiva onto the bleb. And this is a post-operative 3-month picture where the patient is seen to have a cataract and a very well adhered conjunctiva, and there is no scleral thinning that was residual. Another important technique is when you do not have any sclera present with you, or you do not have ologen, the patient is not affording an ologen, you can actually rotate the patient's own sclera onto the scleral graft. So here onto the scleral thinning area, which is a Maumenee's patch repair of scleral patch necrosis. The important thing to note is that bleb-related infections can happen in up to 3% of people who are having very thin blebs and have leaks and they go unnoticed. Most important thing we all know is how to treat a blebitis, and usually it's a very difficult thing to treat, but the prevention of blebitis is important and is fairly easy if you make the patient aware of the fact that there is a bleb present in the eye. It's important to avoid trauma. Use of polycarbonate glasses in such patients must be advocated. Also, you need to tell the patient that once in a while they can just lift up the upper lid and see whether there is a redness swelling around the area which is where the bleb is present. Also, we used to direct these patients to keep a eye drop of moxifloxacin at home all the time. In case if there is any redness, the patient can start putting the eye drops, and the very same day, or if the patient comes from afar, very next day he can present to the hospital. So this counseling is very important for the patients. And another scenario which already has been discussed by Dr. Ratni ma'am is how to assess and manage a failing bleb, which are of usually 2 types: hypervascular flat failing bleb or encysted blebs. And in hypervascular flat failing blebs, not just 5-fluorouracil, we have also used mitomycin C 0.04%, only topical mitomycin with the help of a Mirocil sponge, which is kept for 3 minutes over the bleb area and washed off. And there is definite reduction in the conjunctival vessels. Also, along with that, as Dr. Harsh sir has said, that ocular massage is a very important thing. So with a hypervascular flat failing bleb, ocular digital massage has to be taught to the patient. And always do a gonioscope to look for any internal blockage so that that can be removed. And cystic blebs usually have a tenon cyst formation and they require needling. And late bleb failure, which can happen due to subconjunctival fibrosis. A paper by Professor Sihota on 10-year follow-up of trabeculectomies that she has done, it shows that in long term, 50% of the patients, they do not need any medications after trabeculectomy, but around 45% of patients might need 1 to 3 medications. Majority of them, you would usually need only one medication to achieve the target IOP. So it's important to understand that after you have done a trabeculectomy, the target IOP has to be looked at. If the target IOP is not achieved and it is a hypofunctioning bleb, then we have to give 1 or 2 medications to achieve the target intraocular pressure, and side by side other procedures might be done. So thank you very much. This is all about my talk about the failing blebs, also about the hyperfunctional and the thin cystic blebs. Thank you.
Extremely wonderful talk, and so many beautiful videos have been shown which are so self-explanatory. So paucity of time, we are going to go on to the next speaker, though you really justify a whole lot of panel